So first question this week was, I can roll my QLs and get instant relief, but they tighten back up again. So this is a very common one we see in the clinic, and I used to be that guy that used to stick my elbows in QLs and cause a lot of pain. So how I look at it now is the QL, it attaches to the rib cage and it also attaches down to the pelvis. So that's given us two big clues. So that makes it a little bit trickier. So for me, I would be asking myself the question in my own head is, right, what's not doing its job to cause this QL or cause the nervous system to cause the QL, or whatever way we want to say it, to have some kind of protective tone. So that could be when I reach for something. So if I go to lift something up and I don't have a good co-contraction of my elbow, I'm not distributing that external load well through my upper limb, all the way through my rib cage, all the way through. So my next question to you would be, what's in your injury history from your fingernail right through to your rib cage where your QL attaches? Or we could look at it from the other way. When your foot hits the floor, we have to overcome our body weight, overcome gravity. Is there something from your toenail all the way up to that pelvis that's not doing its job? So when your foot hits the floor, your nervous system has to go, whoa, I need a little bit more stability here, and that's causing maybe your QL to tighten. So that's where, and again, I apologize, you're probably going to be sick of me saying this, but we link your story from the subjective assessment right through to your objective assessment. And that's what's different to this. And that's really where in my mentorship, it's all about the fundamental principles and understanding how everything links together. It's not about teaching you a couple of exercises and going and doing it. You could train a monkey to do that, okay? It's about having the ability to think for yourself, and it goes back to that key word, which I think is massively undervalued, and that's clinical reasoning. Anytime you go on a course where they just give you exercises and go, okay, if this test is like this, do that. That to me is a serious lack of clinical reasoning, and that's where we have to be better, and we have to clinically reason everything we do from the second the patient walks in the door to the last interaction with them when we discharge them. Clinical reasoning is key. So last question was any advice on MCLs, when to brace, and any advice on return to play. So again, I personally don't brace if I can help with grade 1s and even low grade 2. Sometimes if they were clinically very good, we may choose not to brace them. But obviously if it's starting to get into a grade 2 and a grade 2 plus, again, all these categories are a little bit vague with radiologists. But if the key thing for me really is if the person's stable in extension, I think that's the first big thing that we'd want. And then a lot of it is how they present clinically. One of the biggest KPIs for me is restoring full knee flexion, okay, without getting any catch or any symptoms, as strange as that sounds, because that's going to be very, very important when we get back to high speed running. The other big thing that I want is I want a really, really good motor output through the medial gastro and the medial hamstrings. So again, when that foot hits the floor and when we strain or when we even stress the MCL, you need a reflexive contraction of your medial hamstrings, just like with the ACL, okay? So again, we want to restore that ability of the timing of the hamstrings, especially the medial hamstrings, to fire when we have when we have intent through the foot, basically. So that's something we're working on, whether they have a brace on or literally day 2 post injury, is restoring that intent through the midfoot to get that timing between the foot up into the knee, restore co-contraction and get everything doing its job. I'm then a big fan of using Gary Gray style lunge matrix, it's called, where you're keeping your foot planted and then you're rotating and you're pivoting in 3 dimensions. I think that's a great way to get greater exposure to these tissues. So at the start we're doing it quite slow, then obviously we're going to be progressing it up in increasing the speed of movement, and then you can use hand drivers as well there. But I would only do that when we've earned the right to progress to standing, okay? So again, on the bed, we want to get that intent through the foot up into the medial hamstrings. When we have that, then we progress into standing with this stuff. So again, there's no real bad exercises, but the art of this is getting the timing of the exercises correct. The nice thing about this as well is this is also the start of your graded exposure for change of direction. So we literally are working change of direction mechanics literally from day 2 post injury, which is nice. Then it's a case of increasing low tolerance. So then we're going through the progressions I teach in the mentorship, where again we'll use slouches, we'll use various other things, we'll use a concentric focus, an eccentric focus, an isometric focus. We'll go through our hopping progressions, and then once we've done all those, there's no reactions, there's no apprehension. Obviously we're biased in certain directions depending on our assessment, and then once we get there, then it's when the patient's running, then it's plain sailing. But if you don't have full knee flexion and you didn't go through your KPIs in the right order, that's where your pain in the ass then is when you get back running and that person looks limpy as.